Well, I think if there are no other questions, we can continue obviously talking after the imaging section. So we're still going to keep going on morphology. So many more questions related to morphology are very welcome, but we're going to focus now on the imaging side. The next speaker will be Dr. Jackie Weinberg, and Jackie is currently our acting director for fetal cardiology here at Children's Hospital of Pittsburgh. And she'll be talking about fetal diagnosis.
Okay, good morning, everybody. We are going to talk about, as Jackie said, the fetal diagnosis of the functionally univentricular heart. Hopefully. Okay. So luckily, this is one category of congenital heart disease in which the majority of cases are detected prenatally. These are a couple of representative studies that, as you can see, indicated by the stars, there's a high rate of detection in fetal life or prenatal diagnosis for these lesions. This is because these lesions are almost always visible on the four-chamber view, which has long been part of the screening obstetric ultrasound at mid-gestation. This is a normal four-chamber view, and as we play it, we can see on the screen 4 chambers. There are 2 atria, 2 AV valves, and 2 ventricles. And we do spend a great deal of time looking at the morphology of these chambers and determining which is a right ventricle and which is a left ventricle, as well as the connections between the atria and ventricles and arteries. As opposed to in this view, this is a fetal echocardiogram at about 20 weeks gestation. And in this example, we do see 2 atria and 2 AV valves, but only 1 recognizable ventricular chamber. Annotated here, we can see anterior and posterior, right and left on the fetal chest. And again, as the sweep starts, 2 atria and only a single ventricle, which was felt to be of left ventricular morphology. As it sweeps through, we can see that there are 2 outflows, although they are discrepant in size, with the early branching vessel, the pulmonary artery, seen smaller than the aorta and posterior to the aorta, which is an abnormal relationship. This is the same fetus a little bit later in gestation, and we had diagnosed double inlet left ventricle. On the left screen, we can see that there, again, 2 atria, 2 AV valves, and a single recognizable ventricular chamber, which was felt to be left ventricular morphology. And as it sweeps through, we can see a smaller pulmonary artery and an anterior larger aorta. On the right side of the screen, this tips towards the ventricular septal defect, and we can, in this view, see that hypoplastic anterior right ventricle, which in this example, the left ventricular chamber gives rise to the pulmonary artery and the right ventricular chamber gives rise to the aorta, thus discrepant ventricular arterial connections. There was also subpulmonary narrowing or crowding, leading to pulmonary stenosis in this case. A different example of double inlet left ventricle in the fetus. On the left-hand panel, we can see, again, 2 good-sized atria, 2 AV valves, and a single dominant or a dominant left ventricular chamber, only a single ventricle seen in this view. In the middle, we can see where the red arrow is, the plane of that ventricular septal defect, and the smaller right ventricular chamber. And on the right side, this is a sweep up to the outflows, and in this case, we see the aorta arising posterior and more related to the left ventricle, and the pulmonary artery is anterior, consistent with normal ventricular arterial connections in this case. Also, as was mentioned before, called the Holmes heart. This is another example of maybe a double inlet left ventricle. In the clip on the left, we can see, again, a single or a dominant ventricular chamber that appears to be left ventricular morphology. The attachments of the AV valve go to that anterior wall and do not connect to the ventricular septum. There is a VSD and a hypoplastic RV, morphologically RV chamber, as was seen in other views as well. And when we sweep up to the outflows, in this case, the pulmonary artery, which is the larger artery that branches early, was seen coming off of this dominant chamber, with the aorta more leftward coming off of the hypoplastic chamber. The question was, does this represent a double inlet left ventricle, although only a single AV valve was seen, thus atretic left-sided AV valve, or a different entity? But either way, represents a single or a dominant left ventricular morphology. Moving on to tricuspid atresia. In this example, as we can see in the left pane there, we can see again two atria. The dominant ventricle, the larger ventricle here, was again felt to be a left ventricular morphology with a hypoplastic anterior right ventricle. There was no connection visualized between the right atrium and the right ventricle, and so was felt to be tricuspid atresia. Same fetus we can see in the middle pane here, and sweeping up towards the outflows. And here we see a VSD between the right and left ventricles, and the larger pulmonary arteries come off of the hypoplastic right ventricle. So concordant VA connections. On the right was sort of a short axis sweep up, seeing the VSD and seeing a smaller aorta come off posteriorly. This sweep is actually anterior to posterior, and so we see the pulmonary artery and then the aorta as you go back towards the atria. In this example of tricuspid atresia, there was again a only recognizable single ventricular mass there, and a normal LA to LV connection with no connection seen from the right atrium to a ventricle, and thus felt to be tricuspid atresia. This fetus also had pulmonary atresia, and so the right ventricle was very severely hypoplastic and hardly recognizable. In the same fetus with pulmonary atresia, we often see flow provided to the pulmonary arteries from the arterial duct, which in this case comes off the underside of the aorta, and the blue flow seen up there is retrograde flow to the pulmonary arteries. One last example of tricuspid atresia where there is a normal LA to LV connection and good-sized left ventricle with a hypoplastic right ventricle. And on the right side, there are the pulmonary artery appears to come off of the left ventricle, and the aorta arises from the hypoplastic anterior right ventricle. It's a little difficult to see in this one, but this is an example of discordant VA connections with triatresia. Here is an example of pulmonary atresia with intact ventricular septum. So on the left, we can see recognizable four chambers. There's a right atrium. There is a tricuspid valve between the right atrium and right ventricle. However, this is hypoplastic and poorly mobile. The right ventricular cavity is severely hypoplastic and very hypertrophied, muscle-bound, and poorly contractile, with a normal appearing left ventricle. In the clip on the right, it's a similar view in a different fetus with the same anatomy. In these fetuses, we do look for abnormal coronary flow or connections, and although this is not officially diagnosable, in most cases in fetal life, we can see with the color scale low on this clip on the left that there's color flow within that ventricular myocardium suggestive of abnormal coronary connections. On the right, this is the typical appearance of the pulmonary arteries with pulmonary atresia. On the right side of this clip, there's the red flow represents retrograde flow from the arterial duct. And now moving to the more common variants of the functionally univentricular heart that we commonly see, hypoplastic left heart syndrome. This is an early gestation, about 20 weeks gestation clip on the left, where there is a dominant ventricle with right ventricular morphology and a normal-sized right atrium. The asterisk shows you where we believe the very severely hypoplastic left ventricular mass to be. In another example on the right, again, they're seeing a dominant right ventricle with a very hypoplastic, severely hypoplastic left ventricle. And these were both examples of mitral atresia and aortic atresia. However, as others have discussed, in some cases, the left ventricular hypoplasia may be less significant or less severe. In this example on the left, this represented a fetus with a hypoplastic stenotic mitral valve and aortic valve, and the left ventricle is recognizable, although notably smaller than the right ventricle, even at mid-gestation. The example on the right is of mitral stenosis with aortic atresia, where there is a very hypoplastic and poorly mobile mitral valve visualized, a hypoplastic but notably hypertrophied left ventricle with the endomyocardial fibroelastosis that's been discussed. Also of note, the right ventricular function is abnormal in this fetus. We sometimes see this play out in real time in the fetus, this progression of disease. So on the left is a fetus that we scanned at about 20 weeks gestation, and at this time, the left ventricle was noted to be significantly dilated with very poor contractility, and it does appear echo bright even at this point. This fetus had significant aortic valve stenosis, and as we saw a few weeks later, that left ventricle had become not dilated at this time, but was starting to become hypoplastic. And as seen in the far right image, the LV is no longer anywhere near apex forming, remains echo bright and poorly contractile. The typical appearance of the aortic arch in hypoplastic left heart syndrome, we can see the red flow represents retrograde flow in the aortic arch fed by the arterial duct. And this fetus with mitral stenosis and aortic atresia, this is the same clip as another I showed a few slides back. This fetus also had another finding that we can see in the right panel. The very small jet of color between the left atrium and the right atrium represents a very restrictive connection between the atria. We were very worried about a restrictive atrial septum in this baby. When we used Doppler to assess this, there was a high velocity and a very narrow color jet that crossed the septum, as you can see in the clip on the left and the Doppler on the right. And the pulmonary vein Doppler was significantly abnormal. So in fetuses with restriction to egress from the left atrium through severe mitral stenosis or mitral atresia, in fetal life, one way that we assess this is through the pulmonary vein Dopplers. And as the pressure increases in the left atrium due to poor egress, the Doppler pattern becomes more to-fro. So a normal pattern is seen on the left with decreased flow with atrial systole, but not cessation or reversal. However, as commonly seen in hypoplastic left heart syndrome and other similar conditions, we can start to see atrial reversal as well as decreased forward flow. And we use the ratio of the VTIs, the Doppler tracings, between forward and reverse to assess this. Tracings where the ratio is greater than 5 are felt to be not as concerning for restriction, whereas ratios of less than 3 are very concerning for significant atrial septal restriction that will cause instability in the postnatal period and a high likelihood of requiring urgent intervention. A couple of other entities, very briefly, that are physiologically similar to the hypoplastic left heart. This is an unbalanced AV septal defect with a dominant right ventricle. As we can see in this example, there are 2 atria. There is a large primum atrial septal defect between the RA and the LA, and there's a dominant right ventricular mass with a very hypoplastic left ventricle. On the right side, we can see a hint of a very small aorta and a large pulmonary artery arising from that right ventricle. One last example. Oh, and sorry, this is the tipping up to the outflows. The pulmonary artery arises from that right ventricle. And as we can see in the clip, as well as in the still frame on the right, there is reverse flow in the ascending aorta. This fetus had aortic atresia. My last example, this is an example of double outlet right ventricle with a hypoplastic left ventricle. There is a very small but hypoplastic mitral valve and a larger right ventricle seen there connected with the tricuspid valve. And on the right-hand side, as we sweep up, both great vessels originate from that dominant right ventricle and are of good size. So in looking at these pretty pictures of fetal univentricular hearts, it's important to remember why this is important. The assessment of these congenital heart lesions in fetal life allows for us to determine an accurate diagnosis especially for delivery planning and the care of these babies in the immediate postnatal period to get them to the right delivery location and with the right support that they need. And all in an effort to improve postnatal morbidity and mortality. It also allows us the opportunity to counsel these parents and start their journey into their experience with a baby with congenital heart disease and help them understand both the short and long-term prognosis for these lesions. Thank you so much.